Thank you so much for the opportunity to speak today. Thank you guys for the invitation. I just have one disclosure, and it's not relevant to this talk. Okay, so in response to the growing bariatric surgery community, excuse me, the American College of Surgeons actually decided to release their first bariatric center network accreditation standards. And so those designated those centers as basically admitting or accreditation from the American College of Surgeons. Also, at the same time, the American Society for Bariatric and Metabolic Surgery, the ASMBS, founded within their mission to also release another set of standards, creating the Bariatric Surgery Centers of Excellence. And what happened was these two Center of Excellence criteria were basically every hospital had to adhere to all of these criteria. So you had two separate accrediting bodies for bariatric surgery. While both programs were great and they had great aims in terms of leadership of surgeons and recognizing that obesity, the disease of obesity needed to be treated by multidisciplinary teams, as well as looking at their outcomes, it created a large problem. So what happened in 2012, the ACS as well as the ASMBS decided to basically unify their standards, and now creating a joint metabolic and bariatric surgery accreditation and quality improvement program called the MBSAQIP. So then this new joint program accredits both inpatient and outpatient centers throughout the United States and Canada. And it also signifies that these centers have undergone an independent, voluntary, and rigorous criteria. And then they also adhere to the national standards. And then they also submit all of their data in terms of their outcomes directly to the ACS, which is a joint venture. So this program, the MBSAQIP, is great because it creates uniform standards, and then it also supports continuous quality improvement. So the MBSAQIP registry is a great resource. It's a prospective database, and it contains risk-adjusted, clinically rich data, and it's based on standardized definitions, based on procedures, all metabolic and bariatric procedures, not only performed by bariatric surgeons, but also non-bariatric surgeons. And so it contains patient-level aggregate data, but it doesn't identify any of the patients, the hospitals, or the healthcare providers. So the MBSAQIP registry is actually the largest bariatric-specific clinical data set in the country. And in 2019, there were over 200,000 cases that were reported from over 860 centers throughout the United States and Canada. The other thing about the MBSAQIP, it also has post-operative data for 30 days, the mortality and morbidity outcomes. So in terms of revisional surgery, so the bariatric surgical volume has obviously increased, as you can see here, exponentially. And in 2018, over 250,000 bariatric cases were performed. As obesity is a chronic remitting disease, along with the increasing numbers of failed bariatric surgery, revisional surgery is actually gradually increasing. And as you can see here, in 2011, it was just 6%, and in 2018, it's risen over 15% of the cases. So revisions are usually performed for refractory comorbidities, surgical complications such as gastric fistula, marginal ulcers, but also weight regain as well as inadequate weight loss. The interesting thing about the patients that are actually undergoing these revisions is if you look at the study done by Clapp et al., the patients actually, they have less comorbidities than compared to patients that are undergoing primary surgeries, meaning that, they have actually kind of gotten some benefit from their previous bariatric surgery. And it looks like they do actually tend to have more complications, but I think that that's related to the fact that these are complex operations. And so when looking at the data, it's not going forward. Okay, there we go. When looking at the data in terms of the trends of actual cases, so if you look at the MBSAQIP database and you look at the revisional cases that are being done between 2015 and 2017, as you see here, the authors of this study found that the revisions are obviously increasing, and we know that, but the most common revision is actually gastric bypass, it's actually the removal of a lap band with conversion to a sleeve gastrectomy. And then the second most common procedure is the removal of the lap band and conversion to a gastric bypass. Now, the problem with this data is that some of the CPT codes at this time were not clear, and the revisions, the actual procedure, index procedure, was not clear. So this data can be a little bit muddled. So what about the complication rates in terms of the procedures? Is revisional surgery actually more complicated for the patient, and what complication rate should you quote these patients? Well, when you look at the data from 2012 to 2015 of the MBSAQIP data, it shows that, yeah, it is actually a little bit higher. The actual complication rate is about 14.3% in those patients undergoing. Now, this is a small study. It's just 84 patients over that time period. However, the primary revisional complication rate is less than 2%, so it is a little bit higher. And then if you look at the complications, only about 6% of the patients actually underwent a complication, and most of those complications were over 30 days out, so they were late complications. So what about single stage? So we've had a lot of these failed gastric bands, and so the question is, a lot of times, can the patient undergo a single stage operation, removal of their gastric band and immediate conversion to some procedure, either sleeve or gastric bypass? In this study, looking at the 2015 data, the authors of this study, they actually found that there were no mortalities, but they did find that the patients who underwent conversion to gastric bypass when compared to sleeve, they had increased clinically anastomotic leak rates and statistically significant increase in bleeding events, 30-day readmissions, as well as reoperations. And they also found that the length of stay and the operative time for these cases were a little bit higher in the gastric bypass group, as well as superficial site infections, as well as pulmonary embolism. So they conclude that it's safer for the patient to undergo removal of the lap band and conversion to a sleeve compared to gastric bypass based on this data. However, this study was underpowered to really show that. So what about the difference in approach? Does it matter? So when looking at this study, so in terms of laparoscopic versus robotic, so looking at the MBSAQIP data from 2015 to 2016, this study looked at those patients, and they found that there was a significant difference with respect to the operative time, as with the robotic group taking a little bit longer, 167 minutes as compared to 103 minutes, and there was a statistically significant increase in the length of stay. However, there was no difference in terms of postoperative complications between the two groups. And then this is an updated study including more MBSAQIP data, so 2015 to 2017. And this study actually found that there was no difference in the overall incidence in terms of 30-day serious adverse events, organ space infections, reoperations or interventions, and it was actually lower for the robotic group compared to the laparoscopic group. And however, they did show that yes, it does take a little bit longer in terms of those patients with the robotic group as compared to the laparoscopic group. So, the MBSAQIP data is robust, but there is some problems with the data. The CPT codes can be misleading. There's a lot of things that are missing. Key surgical details are not revealed. Anastomotic techniques definitely make a difference in terms of patients' outcomes. Surgeon experience, especially with something like a robotic platform, makes a huge difference. The sample size is definitely very small. There's not that many revisions, although that number is increasing, and the follow-up is pretty short. And then we have to remember, anytime we look at the MBSAQIP data, even though it is prospectively collected, the data, when you analyze it, it is retrospective analysis, and it is subjected to those retrospective biases. So what do we do with this data in terms of counseling our patients? So the MBSAQIP has just released this new risk benefit calculator. And as you can see here, I'm inputting the patient data for a patient that I saw in clinic in terms of looking at their risk in order to determine their outcomes. So this calculator is great because it takes 20 patient-specific comorbidities, and you can input it into the calculator, and then it generates the likelihood of having a postoperative complication at 30 days. And so as you can see here, and you can actually look at it based on different procedures, so lap band, sleeve, and then gastric bypass, and you can see that the actual outcomes in terms of death, mortality is pretty low. It's less than 1%, and then any complication is about less than 30%. But the data from, even though it's from 700,000 cases, the data is only for primary cases and not for revisions. So this has to be taken with a grain of salt. So what have we learned from this revisional data from the MBSAQIP? Well, revision surgeries are increasing. There are a number of failed surgeries, and obesity is a chronic disease that needs to be treated. So, we still have to offer our patients something for their comorbidities. Remember that these patients are going to have possibly less comorbidities owing to the fact that they've already had a procedure, and so they might be a little bit safer to undergo a procedure. Revisional surgery, we know, is safe. They do have increase in terms of postoperative complications because they are complex procedures. There are some operative considerations that we need to take into account. So, if you do not feel comfortable with a robotic approach, then laparoscopic might be a better in your hands for this procedure. And then when counseling a patient, the MBSAQIP is great for guiding your decisions and talking to the patient, but it is limited data, so we need to take that with a grain of salt. Thank you so much.